BTK inhibitors in CLL. Redefining first-line therapy. Welcome to the GlobalRPh YouTube channel, your trusted resource for clinical excellence and evidence-based medical education. Our content is designed for physicians, pharmacists, medical students, and healthcare professionals seeking in-depth insights into current therapies, emerging research, and practical applications in patient care. This video provides a quick summary of our latest blog article. For more in-depth coverage, please see our blog article on the GlobalRPh website. Introduction: the management of chronic lymphocytic leukemia, CLL, the most prevalent leukemia in the Western world, has evolved significantly with the advent of BTK inhibitors. These agents have largely replaced chemoimmunotherapy as the frontline treatment, offering superior progression-free survival, PFS, and reduced toxicity. Ibrutinib, the first-in-class BTK inhibitor, demonstrated a 7-year PFS rate of 83%, establishing its foundational role. More recently, fixed-duration regimens combining BTK inhibitors with Venetoclax, a BCL2 inhibitor, have gained prominence. Notably, the Ibrutinib-Venetoclax combination received EMA approval based on the GLOW and Captivate trials, both of which showed significant improvements in survival and minimal residual disease, MRD clearance. Mechanistic basis of BTK inhibition. BTK plays a critical role in B-cell receptor, BCR signaling, which is aberrantly active in CLL. Upon BCR activation, BTK is recruited to the membrane, autophosphorylates at tyrosine 551, and activates downstream targets such as PLCG2. This cascade ultimately leads to NF-κB activation, enhanced cell survival, and proliferation. BTK inhibitors block this signaling, depriving CLL cells of critical survival cues, especially those derived from the lymphoid microenvironment. While they do not cause immediate cytotoxicity, BTK inhibitors mobilize CLL cells into peripheral blood, where they are more vulnerable. This mechanism underpins the initial lymphocytosis seen with therapy. Ibrutinib irreversibly binds to the C481 residue on BTK. However, its off-target effects on epidermal growth factor receptor, EGFR, and ITK contribute to side effects such as atrial fibrillation. Second-generation BTK inhibitors, such as Acalabrutinib and Zanubrutinib, have improved selectivity and fewer cardiac toxicities. Combining BTK and BCL2 inhibitors. Venetoclax directly induces apoptosis by antagonizing BCL2, an anti-apoptotic protein overexpressed in CLL. Its high specificity reduces the thrombocytopenia seen with earlier BCL2 inhibitors. BTK inhibitors increase CLL cell dependence on BCL2 and upregulate pro-apoptotic proteins like BIM, making Venetoclax more effective. This synergy allows the combination to target both proliferating and resting CLL populations. Trials have shown that adding obinutuzumab further enhances MRD clearance. Key clinical trials. GLOW compared Ibrutinib Venetoclax, I+V, to chlorambucil obinutuzumab in older or comorbid patients. I+V reduced the risk of progression or death by 72.7% and demonstrated superior minimal residual disease, MRD clearance, and overall survival. Captivate used MRD to guide therapy duration. Patients with undetectable MRD had similar outcomes whether they continued or stopped therapy, supporting fixed-duration regimens. Amplify evaluated Acalabrutinib Venetoclax AV and Acalabrutinib Venetoclax obinutuzumab AVO versus FCR or bendamustine and rituximab BR. Both AV and AVO showed superior progression-free survival and response rates. AVO achieved the highest MRD negativity, 95%. Emerging therapies. Next-generation combinations aim to deepen responses and overcome resistance. Ibrutinib plus Venetoclax plus obinutuzumab. In Phase 2 trials, this regimen achieved 85% undetectable MRD after 13 cycles, even in high-risk populations. Zanubrutinib plus sonrotoclax, a novel combination of a next-gen BTK and BCL2 inhibitor. Early studies show 100% response rates and 90% MRD negativity in blood. The safety profile is favorable, with no tumor lysis syndrome events reported. Overcoming resistance. Resistance mutations, particularly C481S, reduce the efficacy of some BTK inhibitors. Inhibitors like Ibrutinib retain activity against these mutants. BTK degraders, such as BGB 16673, go further by eliminating the BTK protein entirely, showing promise in heavily pretreated patients, including those with Richter transformation. Guideline and regulatory updates. NCCN guidelines now prioritize fixed-duration BTK/BCL2 combinations. Acalabrutinib Venetoclax regimens have Category 1 status for first-line use in patients without TP53 mutations. Ibrutinib is recommended in relapsed settings post-BTKI failure. European regulators have approved I plus V and A plus V combinations, while FDA approval is pending despite strong guideline support. Optimizing first-line therapy. Choosing between fixed duration and continuous therapy depends on patient factors. Fixed duration regimens offer treatment-free intervals and potentially lower cumulative toxicity. Continuous BTK inhibition, while logistically simpler, is typically favored in patients with TP53 aberrations due to its long-term disease control. IGHV status also informs treatment. Unmutated IGHV patients respond better to targeted combinations than to chemoimmunotherapy. Data increasingly support individualized approaches based on genomic risk and patient preference. Conclusion: BTK inhibitors have transformed CLL therapy. When combined with Venetoclax, they yield deep, durable remissions and offer viable time-limited treatment options. Ongoing research continues to refine these regimens and explore novel agents. With multiple, effective, well-tolerated options now available, CLL treatment is entering a new era of personalized precision medicine aimed at improving both outcomes and quality of life. Thank you for watching this GlobalRPh presentation. If you found the content valuable, please consider subscribing and giving this video a thumbs up. Your support helps us continue delivering high-quality, evidence-based medical content tailored to healthcare professionals like you. We have more in-depth topics and clinical insights coming soon, so stay tuned and we'll see you in the next video.